being here. Hello, everybody. Keith and Ray, and there may still be one or two people that bump in over the next 2 or 3 minutes. But in the meantime, I'd like to introduce you guys to Dr. Matthew Eschelbach. And Dr. Eschelbach is here with us from Oregon right now. He is a lecturer, EMS director, emergency physician up in that area that is wonderful about helping us each month with helping you guys with some lecture time to make sure that you're getting what you need. And tonight's topic looks like one that we get asked for a lot because I know that the EKGs are difficult at times. We have a lot of folks that struggle with the EKG qualifying exam, and it requires that you pick these EKGs apart on live patients with some very difficult strips. So hopefully this will help make things even better for you. I am going to mute my microphone and turn this over to Dr. Eschelbach, so have a good time.
All right. Welcome, everybody. So tonight we're going to talk about EKG training, particularly STEMI, and we'll go through one step at a time, and then a very systematic approach to attacking an EKG so that we understand how to read it and define the area that a STEMI may be occurring. Objectives is we'll go over some basic EKGs and some basic cardiac anatomy. We'll look at infarcts and ischemia, regional changes. We'll discuss briefly what goes on after you diagnose a STEMI. We will not discuss the more subtle changes, and we'll kind of try and stay out of the weeds. So first thing is, when it comes to any code situation, don't panic.
My first code. See, here's how it works. Someone's heart fails, they beep everyone. The first doctor in has to run the room, tell everyone what to do, basically decide if they should live or die. What, am I crazy? You chicken. Don't worry about the patient. Turk was already there, learning by doing. Plus, it turns out the guy was just sleeping, attached to a faulty monitor.
Okay, so I want you to look at this image and try and keep it in your mind. EKGs are like anything else that you see and recognize. If you look at them on a daily basis, you know exactly what's going on. So why do I call a fork normal and a spoon abnormal? This is totally random, but if you're waking up in the middle of the night, or it's dark and all the lights are off, and you're trying to put your hands in a drawer to recognize something, you know what a fork looks like and feels like. You know what a spoon looks like and feels like. And that's what EKGs are. If you look at enough of them, it doesn't matter what time of the day or night it is, all you have to do is do a quick glance or a quick feel, and then you know what you're dealing with. So I'm going to ask you as we approach this, what you're looking at. Is it a fork or is it a spoon? Is it normal or is it abnormal? And once you get a good appreciation of what normal is, then abnormal becomes easy, and we just have to approach what's going on. So we'll look at our cardiac cycle. Very easy. We've got a sinoatrial node is where the first impulse happens. When you get depolarization of the sinoatrial node, you get a P wave. And then that travels to the atrioventricular node. When you get depolarization of the atrioventricular node, we get the QRS complex. And the bundle branches begin to grab the signal. They go down together at the same rate, and we get a nice thin QRS complex. And that's what happens with an EKG. And then we go back to the next cycle where the T wave happens and you get atrial repolarization. And then we're ready for the next cycle. When we talk about infarct and ischemia, we're going to talk about a continuation or a continuum of change from normal state all the way down to infarction. So once myocardial cells become deprived of oxygen, they start to show a certain pattern that goes from normal to ischemia to injury to infarction. And this is a continuum that we can see on the EKG, and we'll talk about that in a few minutes. So because coronary arteries are the ones that supply regions of the heart, as we begin to look at injury patterns, we'll be able to determine where in the heart injury might be coming. Blood supply arrives to the cells, and if we don't have a good supply of blood and oxygen, we start going from ischemia to injury to infarct. Ischemia has a few things that are very, very common. Number one is some ST depression, and the ST segments become flat or downward sloping like this. Flipped T waves, remember that T waves are usually upright, now are flipped, and this is also an indication of ischemia. And there's a regional distribution, meaning we're going to go over this ad nauseum till the end, because as we're talking about certain regions, we'll be able to determine whether or not the injury is happening in that area. All right, remember, image is everything. So this is a fireman's hat. So if I have Wes out there, I believe, Wes, could you put your mute on? Wes Chandler. Thank you. This is a typical fireman's hat with the front and the back. This is what we talk about when we talk about fireman's hat or tombstones, which we'll go over in a few minutes. Of course, it's that time of year where we have to have the correct image for everything. Okay, so take a look at that fireman's hat you just had in your mind, and here it is again, with the peak up front, the back of the hat, and the tail of the hat right there. Injury, where the ST segment has elevation, with or without T-wave changes can happen. ST segments can be flat or elevated, and they can be convexed up here as well. So if you take a look at this slide, you'll see where we go from our normal state, where we have our P wave and our T wave both upright. And as we slowly begin to get anoxia or lack of oxygen, you can see the first thing to happen is that T wave will flip, and then that ST wave will begin to elevate until it's further elevated, and then we start to get this typical fireman's hat here and here when we're heading on to injury, and when we hit to infarct, we've got a full-fledged ST elevation. Eventually, Q waves will come. These come at a time down the road. So as we look at the anatomy of the heart, these are the arteries that supply the heart. The heart is the only organ that actually supplies itself. And the most common arteries of injury are the right coronary artery. And then we'll talk about the left coronary artery with a branch off the left coronary artery called the circumflex, and then the left anterior descending. So remember I said that injury patterns occur in a regional distribution. So as we talk about regional injury, keep in mind that these are the areas that we're talking about. For example, our septal leads, V1 and V2, are supplied by the left anterior descending. Okay, here's our left anterior descending. Our anterior leads, V3 and V4, are also supplied by the left anterior descending. So when we have injury to septal and anterior leads, it's the left anterior descending we're talking about. Inferior leads, 2, 3, and AVF are supplied by the right coronary artery. Here's our right coronary artery. And lateral leads, V5, V6, 1 and A, AVL, are supplied by the left anterior or circumflex. And there's our circumflex and left anterior, left coronary artery. Posterior is not shown in this picture, but in the 12 lead, we'll talk about that further down the line, and that's supplied by the right coronary artery. And here's our right coronary artery, which is going to be the posterior aspect of the heart. When we talk about infarct regions, this is the little box that you should have memorized. This is probably in your little flip books. And we talk about certain areas. Lateral are 1 and AVL. That's easy because L has lateral in it. And then V5 and V6. Inferior leads, 2, 3, and AVF. Septal leads, V1 and V2, and anterior leads, V3 and V4. Keep in mind that the lateral leads usually talk to the inferior leads. So lateral and inferior regions have reciprocal changes. So what we mean in that is here we've got ST elevation in 2, 3, and AVF. What that means is in our lateral leads, we'll most likely have ST depression. Or here is 1, 2, V5 and V6, you've got ST elevation. These are the reciprocal areas that will probably have ST depression in our inferior leads. Anterior infarcts may not be accompanied by any reciprocal changes. Septal infarct may not be accompanied by any reciprocal changes in any other area of the EKG. What is not a STEMI? Diffuse ST elevation, meaning that you've got ST elevation where there's terminal notching of the QRS here, and a concave ST wave. That is indicative of pericarditis. And that's what that is you're going to see what looks like ST elevation, but it's going to be diffuse, the entire heart. You can have 1, maybe 2 vessels, but you're not going to have 4 vessels having an MI all at once. So how do you explain what looks like an MI all over the heart? Well, the pericardium covers the heart, and that's what pericarditis is. Left bundle branch block also has the appearance of maybe, excuse me, having ST elevation MI. ST settlements in V1, V2, V3 up to 3 millimeters in left ventricular hypertrophy. Early depolarization is not MI. And we'll talk a little bit about asymmetrical T waves later on. And ST segment elevation less than 1 millimeter, although tempting, is not an MI. What is a STEMI? ST of 1 millimeter more with a flat ST segment, ST of 1 millimeter with a convex ST segment, elevated ST segment with a convex ST segment, or a tombstone here. Symmetrical T wave with an elevated ST segment, biphasic T waves, reciprocal changes with a big R distribution, like in a posterior, and we'll talk about those, and then the regional distribution. And what's also very, very important is a history consistent with MI. Somebody who has classic chest pain or atypical chest pain with high risk factors. In 2015, the American Heart Association kind of refined ST segment elevation. And they said a paramedic interpretation of a probable STEMI can happen in women with only 1.5 millimeter of ST elevation in V2 or V3, or in men of 2 millimeters of ST elevation in V2 or V3, or 1 millimeter ST elevation in 2 or more contiguous leads. That has not changed. And sometimes the local ED will call STEMI based on a transmitted 12 lead if available. When we're talking about acute MI, not all acute MI are STEMIs. Sometime we had talked about a few lectures back about acute coronary syndrome, which is not a STEMI, but there's been damage to the heart muscle. STEMIs are the acute MIs that are treated differently by transporting this patient directly to a hospital where intervention can be done. All chest patients are an emergency and should be treated as such, and chest pain potential and non-STEMI patients should go to the closest appropriate facility for further evaluation, and if necessary, they can be transferred at a later time. Acute coronary syndromes. Sudden ischemic disorders of the heart, which includes unstable angina and acute myocardial infarction. And we may not know it's a STEMI until we get blood work back. That's why it takes a while to do that. And these acute coronary syndromes represent a continuum of a similar disease process, and we'll talk about that very soon.
Acute coronary syndrome, or ACS, is the leading cause of death globally. The spectrum of ACS ranges from unstable angina to non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction. Ultimately, ACS is the result of an obstruction of the coronary arteries induced by an atherosclerotic plaque. ACS events are triggered by the plaque rupturing. This exposes subendothelial matrix proteins and other molecules. Platelets are recruited to the site, adhere to the injury, and, together with red blood cells and fibrin, begin to form an arterial platelet-rich clot. This narrows and eventually obstructs the coronary artery. The extent and the location of the blockage and the resulting myocardial damage determine the extent and the severity of the myocardial infarction. Life-threatening arterial clots are formed through two pathways: activation of platelets and generation of thrombin by coagulation factors. Targeting both pathways has been shown to be a viable therapeutic approach.
Okay, so the initiating events of acute coronary syndrome are first and foremost plaque rupture, and then thrombus formation, vasoconstriction, which leads to further cutoff of the vessel. So here, for example, are two very different lumens. You can see that the lipid core on the right has a very, very thin structure here, and this fibrous cap is very, very vulnerable. Whereas this is a high cholesterol, but the fibrous cap is very thick. So as the platelets and blood go through this lumen, the chances of this rupturing are much greater than the one on the left.
Woohoo! Look at that blubber fly!
All right, so when our lipid core is exposed and this fibrous cap pops off, that's when the lipid core is exposed to the lumen and the platelets begin to adhere. Our very first few platelets grab on, and then it sets a cascade for coagulation. As time goes by, more and more platelets adhere to each other and aggregate is the word. And when platelet aggregation is complete, we start to form fibrin, and fibrin will kind of tie this all together, and before you know it, vasoconstriction happens and no blood is getting through there, and this is what myocardial infarction is. This leads to tissue death. So the plaque rupture leads to thrombus formation, the coronary vasoconstriction, increased myocardial oxygen demand, call for collateral circulation, and eventually heart tissue starts to die. And it's this tissue death that we can actually measure in an EKG. All right, so let's see how good you are about talking about STEMIs. We're going to talk about, for the next remaining time, just STEMIs and how they change. So give yourself a number. So starting with, I guess, Wes, you'll be number 1, Keith number 2, Ray number 3. Give yourself a number and we'll go through these one at a time. All right, so Wes, unmute your microphone. Tell me what you see in this EKG.
I'll say I don't really see any elevation.
Okay. So let's attack it like we did from the very beginning. So I'm going to ask, is it a fork or a spoon? Fork meaning normal, spoon meaning something scary.
It'd be a fork.
Okay, good. So we say a fork. So it looks mostly normal. Now let's go region by region. Let's go to our lateral leads. 1, AVL, V5, and V6. We see a P before every QRS, so it's sinus, right? We've got ST segments that seem to be on the line, and we don't see any ST elevation. So lateral, good. Now, 2, 3 in AVF. Same thing, a P before every Q, the QRS seems to be on the line, the QRS seems to be skinny, and there doesn't seem to be any ST or T wave depression. So 1, our lateral, now our inferior. Now we go to our septal, V1 and V2. And then we'll go to our anterior, V3, V4. And we've already talked about our lateral, V5 and V6. So what about this upside down T wave in AVR and an upside down T wave in V1? Does that bother you at all?
In AVR, isn't that normal? Both the
Yep.
in the P wave and the T wave in AVR should be the same.
Yep. AVR and V1, they're going to be upside down, and that's normal. So you said this was a fork, meaning normal. You said this was no ST elevation. So you're trying to tell me that this is a normal EKG?
Well, I don't know. I guess I maybe talk myself out of it just by over-studying it.
Stick with your gut.
Maybe,
Go ahead. Stick with your gut.
I'll stick with it that it's more normal than not.
Good. All right. It's a normal EKG. All right. So now this is the fork in the drawer. This is the one that you look at. From now on, this is what you know to be a normal EKG. Everything we talked about, you know that you've got some flip T waves in AVR and V1. We know that we've got skinny QRSs. We've got no ST elevation. We've got a normal heart rate of 72. So that is a good normal EKG. Very good. All right. Number 2, Keith. Let's take a look at this one. Unmute and talk away.
All right, looking at it, I see It's a spoon. um,
Okay, it's a spoon. Why is it a spoon?
so I'm going to use the acronym. I see all leads. So inferior looks good. Septal, not so good. We got V1, V2 with obvious tombstone going into.
All right, tombstones, they're not good. Tombstones are bad.
Now I'm looking for some depression and reciprocal. So I'm looking at V6. I see a little bit of depression down where they
Right,
down
right here,
where
you
the
mean?
yeah. I mean I
A
can't.
little bit of slurring. Okay, I'll give you that. A little bit of slurring.
And
And then
also
we'll
in lead
attack
2.
it. Let's attack it as we did. First off, our eye goes right to this, but we're going to go backwards. Let's go back to 1, AVL, V5, and V6. Those are our lateral leads. And you're saying right there, there's a little bit of ST depression. Okay,
Correct.
that's a very first spoony part. Now let's go to our inferior, 2, 3, AVF. I'm not too impressed anything there. You could say that this F segment here has the same kind of slight depression there. Not enough to write home and call the cardiologist about, but enough to say, that doesn't look quite right. So lateral, inferior, and now let's go to anterior. What's that look like?
Obvious elevation.
Good. And then V3 and V4, which
Also
are
elevation.
septal. Okay, so elevation in anterior and septal region, what do we want to call this EKG?
We're going to call it a spoon or a STEMI.
Okay, good. STEMI, you're going to wake the cardiologist up?
I would. Well, depending on symptoms, if they're presenting with the right
All
history.
right, 55-year-old male who's sweating, diabetic, smoker, and is having chest pain.
Definitely would wake the cardiologist up.
All right, activate it. It's 2 in the morning. All right, good. Anteroseptal MI, ST elevation, V134, just as we talked about. No Q waves yet. ST depression, 2, 3, AVF, and V6, as you picked out. And be careful, this is the type of guy who's going to go into VTAC on you. All right, very good. I'm going to pick on Ray next. All right, Ray, fork or spoon?
Spoon for sure.
Spoon, okay. Let's start. We're going to spoon it and figure out why it's spoon. Other than the fact that it scares the hell out of us by looking at it, let's attack it one region at a time. Lateral leads, 1, AVL, V5, V6. What do we see?
Diffuse ST elevation.
Okay, good. Inferior leads, 2, 3, and AVF.
2 looks pretty normal.
Looks
Maybe.
absolutely normal to me. You're right.
Yeah, 3 and AVF. 3 definitely looks like some ST depression, and then AVF.
ST depression and
I'd say
AVF
same for
has
AVF.
ST depression. Gosh. All right, good. So remember that when we've got a reciprocal lead, meaning lateral with elevation, we have accompanying depression, so there's reciprocal changes. So now let's attack our other regions. V1, how's that look?
Pretty normal.
Pretty normal. Except I'll point out that our T wave is now upright instead of
yeah.
inferior, so that's a little clue that something else is going on. V2, what do you think there?
ST elevation.
Okay, ST elevation, V2, V3, V4, V5, V6. So, what do you think of this? What are you going to call it? Are you going to call it a MI?
I mean, it's diffuse ST elevation.
Right.
Say more pericarditis looking.
No, well, think about it. Is there ST elevation in 2, 3, and AVF?
No, there's not.
You said there's reciprocal changes. So,
Yeah, from lateral.
all right. So we're going to call it an MI.
Yeah, I guess just a really big one.
Right. Anterior and lateral MI. You want to call it an anterior lateral MI?
Yeah, but then what about V2? Why is that?
V2. Right there.
Yeah.
Right there. That's
Oh, yeah,
ST
yeah.
elevation.
Yeah,
V1 is not elevated, but V2
but
sure is.
yeah, but V1 does
There's
have that
anterior.
inverted T wave.
There's anterior, there's septal, and lateral changes. So anteroseptal MI is what I'm going to call this. ST elevation V2, V3, V4 through V6, and V1, V2 and V3 looks acute. So anterolateral MI. So that's good. Okay. Next one. All right. Who is that? Benthal? Is that right?
I think Dusty had a call, Dusty Benthal, so he left, but I didn't want to boot him out of there because it wouldn't let him
Okay.
come back in.
All right. So let's come back to, is that Keith then, or is Keith next?
I think Wes was first.
Okay. It's hard for me to see everybody. So, okay. Wes, you're next then. Oh, where did I go? Sorry. Sorry, I'm going backwards here. There we go. Give me a second here. There's EKG, normal. Okay. Let's go with this one. Wes, are you there? Okay. What I'm gonna tell you is the EKG machine says consider MI. It's 2 o'clock in the morning, you're tired, you're looking at this EKG, and the EKG machine is telling you to consider acute MI. Now you got to talk yourself in or out of it. So let's
talk myself out of it. It looks more like ischemia.
All right, let's approach it one step at a time. Let's look at our lateral leads. 1, AVL, V5, and V6. What do we see?
All have inverted T waves, slight elevation, and 1 in AVL.
Right. So if I look at this, I'm going to go, oh man, that's not quite 2 millimeters, but it's getting there. Here and here. If I caliper this out, it might be 1.5. And then if I look at V5 and V6, what do I notice about these T waves?
All inverted.
They're inverted, okay? So lateral looks a little spoonish. All right, let's go to 2, 3, and AVF. This looks pretty normal to me. What about here? Do we see a little down sloping maybe right there? Little ST depression?
Yeah, so that would be more reciprocal changes to the 1
Yep.
AVL.
All right. Now let's go to V1 and V2 and V3. They're not too exciting, are they? And then V4 is not too exciting either. But now we've got a flipped T wave in V4. So this is kind of maybe an ischemic type of picture, but what it is, it's an early, very early ST depression MI. And what will happen is the second EKG you do over time, these will probably get higher, these changes in 1 and AVL, and they'll come off the baseline. So this is somebody who you're going to let the ER know about early. All right, let's look at our next one. Who's next?
I am.
All right, Keith. Is it a fork or a spoon?
I'm going to go with a fork on this one.
Fork is normal.
Oh, no, sorry. Spoon.
Spoon, okay. Spoon, all right, it's a spoon. Tell me why it's a spoon. Go through it systematically.
So looking at lead 1, we have a downward T wave.
Okay,
2 and 3, and as well as AVF, have a ST segment elevation.
got it.
V1, V2, little to no changes. As I can see, look pretty normal there. V3, V4, also no changes, looks like. And then V5, V6, no changes.
Okay. So we've got a little bit of ST depression in 1 and AVL, right? You
Correct.
talked about 1, but you didn't talk about AVL.
Oops.
So 1 and AVL has ST depression with ST elevation in 2, 3, and AVF. So that's ST elevation with reciprocal changes. What do we want to call this?
I'm going to call this interior MI. Oh, inferior. Sorry.
Yep. Okay, acute inferior MI, exactly. Reciprocal changes in 1 in AVF. Now, I've noticed a couple people do this. When you talk about 1, don't go to 2 next, go 1, L, and then V5, V6, okay? Those are the ones that I want you, that's the pattern. Go attack it top left to bottom right. That's how you go through. Then you go to inferior, then you go to these lateral changes. So good, good. All right, next one. Here we go. All right, Ray, what do you see?
So 1 looks pretty normal.
Okay.
AVL, I think that looks pretty normal too.
Okay.
V5 and V6, maybe some slight ST elevation.
Good. Okay. So a little bit of ST elevation. Good. What do we see in 2, 3, and AVF?
Also some slight pause. I think I see some slight ST elevation.
In 2, 3, and AVF? Okay, so do I. Now, lastly, let's go to our anterior and septal leads.
V1, V2, some ST depression.
Okay.
And then V3 looks pretty normal, and V4 looks pretty normal with, I mean, actually has some ST elevation as well.
Right there. Okay.
Yeah.
So do you want to call this a STEMI?
Yeah.
What regions?
Inferior.
Inferior and lateral,
Yeah,
right?
Yeah.
Good. So inferior lateral MI, a little bit early, but everything you talked about is right there. Perfect. Good job. All right, who's next? Is Wes next?
Yeah, Wes, I think it's back to you, man.
Okay. Sorry, I gotta change. There we go. Here we go, Wes.
All right, so that'll be it's a spoon. You have depression in 1.
I can't hear you, Wes. Maybe get a little bit closer to your microphone.
Yeah. So it's more of a spoon, but I mean it's depression in the leads, especially 1. You have the depression. AVL, you have the inverted T waves. 5 and 6, you definitely have depression. 2, depression. 3 looks relatively normal, a little bit of depression. And depression in AVF.
Okay. So kind of diffuse ST depression everywhere, right?
Right.
All right.
That'd be more
So
ischemic.
that's diffuse ST depression. We give them some aspirin, we give them some nitroglycerin, we give them some oxygen, and maybe by the time we get to the hospital, they might normalize. So that's a good example of what ST depression can do globally. So you can have ST depression in multiple leads. But remember, ST elevation in all leads or multiple leads is more likely pericarditis. So good. All right. Next up is Keith.
Right off the bat, we do have a spoon.
Okay.
Starting off with lead 1, inverted T wave, depression and AVL. 5 and 6 looks normal.
Okay.
In 3 in AVF, we have elevation.
Okay.
1, B1 looks normal. Beside, I think, T wave should be inverted, so that's actually abnormal. B2 had depression.
Okay, right there. Kind of
Yep.
down sloping right there. Good.
Also should be inverted. V3 looks normal as well as V4.
Okay.
So
you want to pull the plug? You want to call a heart 1?
I'm going to call an inferior MI with reciprocal changes in V1, V2.
Good. ST elevation, inferior MI. Very good. Good job. All right. Here's our next one. Who's up next?
I'm up next. So in lead 1, there's definitely an inverted T wave, and then as well as that little strange looking segment.
Strange looking segment. Tell me what that means. A
Mm,
little spoony, right? Okay, so
Yeah.
it's not right here. First off, is it narrow or wide?
wide.
Okay. Is it wide in one place or in multiple places?
Multiple.
Okay. So what happens when a QRS widens? Electrolyte problems, electricity problems, flow problems. So when a QRS widens, what do we see right there? Do you see this right here?
Yeah.
I call that, it's a very sophisticated name. I call that a hitch in the giddy up. All right, I see it here too. So when I see a widened QRS, I start thinking oh, is this a STEMI? Because that sure looks like a tombstone. Or is it a YQRS from some type of bundle branch block? So what do you want to call this?
Right, bundle branch block.
Well, let's look at the most significant is in V1 and V2.
V1, V2. So left bundle
Left bundle
branch block.
All right, so you didn't get sucked in because you immediately saw that something wasn't right there. And then when your eyes go, let's go one back because it's a little bit bigger. All right. You see a little bit of interventricular conduction delay. Remember what's happening in a bundle branch block is you've got to follow my pointer. Here's your atrioventricular node to, the sinoatrial node to your atrioventricular node. And it's supposed to go down both left and right at the same speed, but one takes off a little bit further, and that's why that QRS complex widens. And that's your left bundle branch block because your elevation is, or your widening is up here. So left bundle branch block. Okay, so diagnosing, you will hear later on in your training something called Sarbosa criteria. And diagnosing acute MI in patients with a left bundle branch block is so fraught with peril that the safest course is never even try. There are Sarbosa criteria, but believe me, they're really, really hard. And I think it's best if you stay away from them. And again, look at how wide the QRS is. We saw that right away. Okay, good job. Next is Wes, your turn again.
All right.
Tell me what you see here.
So it's more wide complexes,
Okay.
especially in the V1 through 3. It wouldn't be a left bundle because it's throughout the entire rhythm, not just in the V1 and V2 leads.
Okay. So you want to call it just a bundle branch block?
We could go with that.
Okay. So it's got wide QRS. QRS is down in V1, V2, V3. So it's a bundle branch block. Good job.
So is that like a left and a right, or?
Kind of like both, yeah. Here and here is your left bundle branch, but over here you've got your little right bundle branch with almost, I wouldn't quite call these rabbit ears, but they're getting close. So a not specific bundle branch block.
Okay.
All right, Keith, you're up.
Right off the back at the spoon. Let's see. So looking at, I'm going to start from beginning. Looking at lead 1, can't tell if there's a P wave there, but you can see it in AVL as well as V5, V6. V5, V6 does have a depression. Lead 2, 3, looks like in 2 there is some depression.
Okay.
Lead 3, not enough to tell if there is a depression or elevation. There's not enough QRS. It is a bradycardic rhythm.
Okay, there you go. All right, it's a bradycardic. How slow?
About 40 beats per minute.
Let's see. Here. This is 3 seconds, 6 seconds. So 1, 2, 3, maybe 35 at best. All right. So if we have, let's go back, here's a beat one. What's missing here?
We're missing a bunch of QRS complex.
Yeah, we're missing a whole bunch of QRS complexes. So here you've got a beat, and then you've got a P wave and a P wave and a P wave. And finally, what happens to the ventricle? What do you think this is right here?
Left ventricular. No, it's not a hypertrophy, but
No, not a hypertrophy, but you use the word ventricular. It's a ventricular escape rhythm.
oh,
So intrinsically, the heart and the ventricle is set, the AV node or the sinoatrial node has a underlying pulse of about 60 to 80. And most of the times you're going to see a heartbeat between 60 and 80. The ventricle, if it doesn't receive a QRS signal or a signal from the sinoatrial node, it's going to fire intrinsically at a rate of about 30 to 40. So here we have a rate somewhere between 30 and 40. We got a whole bunch of missed beats. And what do we want to call this? Any idea if I'm seeing a whole lot of space between P waves and a QRS complex?
I almost want to call it complete heart block. Or
Yeah, absolutely. Complete or third degree heart block.
okay.
Yeah, this looks like a left bundle branch block, but it's not. It's a ventricular escape rhythm because that ventricle is set to go off at about 30 to 40. And all of these are kind of big, tall, they're kind of big ventricular escape rhythms. So that's a complete heart block. This person needs a pacemaker. You could try a little atropine first, but it might not be responsive. All right, good job. Who's up next?
So lead one, maybe some very slight ST depression.
Okay, I'll give you that.
AVL looks normal. V5 looks normal. V6 impossible. ST depression.
Good, I see that. Go ahead.
2 in AVF, also ST depression. Lead 3 looks normal. V1, V2, ST elevation, same thing with V3, V4. So I'd say possible anterior septal MI.
Good, anterior septal MI, perfect. ST elevation V1 through V4. No Q waves yet, so it's early. And ST depression in 2, AVF, 1, and V6. Also be aware of rhythm changes in this patient. Good job. All right, next one. Wes, is it your turn?
Yeah, Wes, it's you, man. Wes, are you still here? Wes, if you're still here, unmute your microphone.
All right, sorry. Yeah, my internet's like spotty. So we have depression in 1, AVL 5 and 6. We have ST elevation in 2, 3, and AVF. V1 looks pretty normal. V2, you have your depression, and same with V3. So that would be more of a lateral MI.
Okay. Let me So you're saying at least an inferior MI, right? 2, 3 in AVF.
Or
All right.
correct.
And then lateral reciprocal changes, 1 AVL, V5 and V6. What is this one right here? Somebody threw in an extra lead.
No idea.
That's cool. Okay. Read it. It says V4R. That's a right-sided heart lead. See how deep V2 and V3 are? If you take your head and turn it upside down and backwards, these ST depressions are so deep that if you turned it or flipped it, what we call a flip test, you would see that that is probably a posterior MI. So it's an inferior posterior MI. Somebody was astute enough to say, okay, this one and this one are so deep that I'm going to do a right-sided heart lead, and there's my ST elevation.
Okay.
Right. So that is an inferior posterior MI. All right, next one.
It's going to be a spoon, but right off the bat, I'm noticing that there are pacer spikes off of the P wave, or
Right.
so you can't call it an MI with the pacer
No, you
spike.
can't. Perfect. Absolutely. Here's a pacer spike. Pacer, 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 pacer. And then what happens with a pacer is the QRS complex just fires and it looks like a PVC. So that's just a pace rhythm. All right. Sometimes the pacer spike is so small that you don't notice it, and you're unable to diagnose acute injury with this pattern. So very good. You didn't get sucked in by that. All right. This is extra credit. Double points. Who's up?
It's me again.
Okay, right.
So 1 AVL, V5, V6. They all look pretty normal.
Okay. I'll grant that.
2, 3 AVF also look pretty normal.
Okay.
V1, V2, some ST depression. And same with V3, V4.
Okay.
Yeah, I don't know what this could be.
All right. You're really, really close. Let's look at V2 and V3 again. All right. So if I were to take that EKG paper, flip it, and hold it up to the light, this is what I would see.
Okay, so probably
Right. Posterior MI. So I'm going to go back and forth with that again. All right. There's my ST depression, which is pretty profound. So I take it, hold it up to the light, flip it, and I've got an acute ST elevation. So this is a posterior MI. All right. Last one.
All right. So depression in leads 1. I mean, it's definitely a spoon. 1 AVL, you have major depression. 5 is pretty normal. 6, you have the depression again.
Good.
To 2, 3 in AVF, you definitely have ST elevation.
All right.
V1, you have I want to say you have the inverted T waves and P waves in one, and then you have, well, if you flip it V2, you would have your elevation, and the same with V3.
Okay.
So it would be a inferior and posterior MI.
Very good.
Okay.
That's it. All right. Very good. Excellent, everybody. So you learned a few things. First off, is it a fork or a spoon? If it's a fork, normal, good. If it's a spoon, figure out why it's a spoon, and then go through your regions and go through your rhythms and figure out what's going on. So, okay. So this is what we have for our acute coronary syndrome. Heart rhythm, we have a number. There's certain times that we do not activate that, and that's in a cardiac arrest with ROSC. With or without ST elevation, we hold off on those. If they're greater than 90, or the blood pressure is less than 90 or respiratory failure, we'll hold off on heart one. Acute stroke patients, we've already got a stroke, so we got something else going on. We got to figure that out first. Of course, DNR patients, and then transfers from hospitals or clinics when the cardiologist has already been consulted. We try and get them quickly to our Bend hospital, which is where our cardiologists are. And if available, transmit a 12-lead EKG. And we talked about all these regions that we went over entirely. And that's it. So any questions out there? Questions about how to approach a STEMI EKG?
Doctor, I have a question for you.
Sure.
So I was once told that you can have a STEMI a ST elevation or a STEMI with somebody that is atrial pace, but not the ventricular pace, is that true or false?
Can you have a STEMI with a atrial paced rhythm, you mean? The answer is yes. I don't have any examples of that in front of me, but it's kind of difficult to ascertain. But you would have ST elevation MI appearance.
So would you, I guess what I'm asking, would you call a STEMI if you have because most protocols would say don't call a STEMI or don't call for a cardiologist when they have a pace rhythm. But if the patient is demonstrating with signs and symptoms of a MI and they have a paced atrial rhythm, should I call it? I guess.
I would let the ER know, and I would transmit the EKG, and I would let the ER doc consult with the cardiologist. I think that would be the best approach.
Copy that. Thank you, doctor.
Anybody else got any questions for Dr. Eschelbach?
All right. Well, thank you, everybody. We'll see you next time.
Thank you all, and I'll have this posted here in a couple of days up on the website if you want to review it for any reason. Thank you, Dr. Eschelbach, and I sent you an email asking you about January. If you get back to me on that, that'd be great.
I will. I'll let you know as soon as I get my schedule.
Thank you. Bye-bye.
Thank you, doctor.
Bye.